So good morning, everybody, and thank you for joining us on this presentation today, where we're looking at how the various chronic diseases uh, are considered to share the same roots. And this is really an important consideration because it turns out that what this program is about is it's about chronic diseases. Now, Dr. Reynolds will later talk about some of the acute events that arise out of a background of chronic disease. But overall, our theme in this total program is really to talk about chronic diseases. Next slide. So when we look at what we're trying to accomplish today, this is going to be a three-part presentation. Okay, the first part, I'm going to talk basically about what is a chronic disease? How do we get to that designation? What are the similarities of the different chronic diseases? And what
Yeah,
are the
you're welcome.
risk factors that actually cause chronic diseases to come into being? And then we'll talk about the acute events that commonly are the result of chronic disease conditions. And then the final part of this, Dr. Fenton will really focus in on what we consider a new day in chronic diseases. And that is, we don't treat chronic diseases today like we did even 10 years ago. And the reason for that is one, we have a better understanding of what they are and what drives them. But more importantly, there's a whole new universe of medications that don't do just one thing. They do multiple things. They treat multiple chronic diseases, which is to the enormous advantage of anybody that's affected by a chronic disease. Next. So the basic definition, a chronic disease. We broadly define chronic diseases as conditions that last for a year or more and require some ongoing medical attention, whether that's medication, multiple medications, or some other kind of intervention, or it's a condition that limit your activities. Now, we know of the major chronic diseases like heart disease, cancer, diabetes, because these are the leading causes of death and disability in the United States, and they drive the $5.3 trillion that we spend every year in healthcare costs. Now, many times chronic diseases have a history of unequal access to care. People who are affected by various major chronic diseases don't often have the same access to care, even though we have good treatments for those chronic diseases. And that's what we talk about when we talk about health disparities and health inequities. Okay, next. Who is at risk? You know that we have spent a lot of time in this past year talking about the disproportionate effect of various chronic diseases. Not all populations are affected equally. For example, in communities of color, we have much higher prevalence rates of things like obesity, high blood pressure, diabetes, cardiovascular disease, strokes, kidney disease. And a lot of times, this risk is disproportionate, not only because of our backgrounds, but because of other environmental issues like where people are born, where they live, where they work, and where they grow old. These non medical factors are called social determinants of health, and they can be positive or they can be negative. When there are negative social determinants of health, for example, if you talk about the importance of appropriate nutrition and healthy nutrition, but you live in a community where there's not a marketplace where you can buy fresh produce, this is a determinant of health that works negatively. If we talk about the importance of exercise, but you don't live in a community where it's safe to go out walking, this is a negative social determinant of health. Okay? You need to be able to make healthy choices and good medical care. If you don't have safe spaces, if you don't have grocery stores, these are problems. If you don't have access to medical providers or hospitals, because especially in the climate today where you have clinics and hospitals that are closing down, these are non-medical issues, but that have huge effects on medical outcomes. Next. Now, when we talk about chronic diseases, I don't think I need to be the one to tell you that there is no system in our body that is exempt from the ravages of potential chronic diseases. The cardiometabolic system, that includes all of the aspects of our circulatory system, our skeletal muscles, obesity, blood pressure, our blood vessels, kidneys, you name it. There are cardiometabolic chronic complications, and we spend a lot of time talking about them. The blood system, blood cells, anemias, leukemias, lymphomas, skin can be involved in chronic diseases. Eczema, those of you who have had long-standing immune-mediated skin rashes, allergies. Endocrinologists, I'm an endocrinologist, so of course the glands of the body can all be involved in chronic dysfunction and diseases. Bones, joints. If you've had a history of personal or family history of arthritis, you know that this is a major chronic disease, and it goes right on down. Neuromuscular, myasthenias, muscular dystrophy, cancers of various kinds, and even as we get older, especially cognitive and neurological problems like Alzheimer's and Parkinson's, amyotrophic lateral sclerosis, multiple sclerosis, schizophrenia, psychosis. Every system that we have is subject to developing one or more chronic diseases. Next. Now, if you think about chronic diseases, there are considerations that apply to everybody. These are the leading causes of illness, disability, and death in this country. And if you look at the risk factors that drive the development of chronic diseases, that list of risk factors is not extremely long. What does that tell you? If you're looking at a list of risk factors that result in chronic diseases, and the list of risk factors is relatively short, but the list of chronic diseases that it can cause is very long, it means that there's a whole lot of risk factors that are going to show up in a lot of different chronic diseases. And that's a major issue that is to be considered here today. Many of these chronic diseases share underlying risk factors that are common, which is one of the reasons why it's such an important development that many of the newer drugs that we have treat some of the same commonly held or shared risk factors. Now, some groups are affected more than others because of factors that limit their ability to make healthy choices, either affordability issues or access issues. A variety of things become important in that situation. Next. Now, what you should know about chronic diseases, and we'll spend the next just couple of minutes talking about this because there are lots of questions that you should be asking. There are things that you should be wondering about. There are things that you should be asking about, things that you should be having conversations about. 3 out of 4 American adults have at least one chronic condition. Almost everybody's got something, okay? Among adults age 65 and older, more than 90%, think about that, have at least one chronic condition. Now, it doesn't have to be what we call a serious chronic condition, but they got something. Among midlife adults, more than 75% have at least one condition. And even among younger people, 2/3 have at least one condition. Now, most of these preventable chronic diseases, and I'm putting an emphasis on preventable because most of the diseases that we are talking about in the CHP Chronic Disease Initiative are caused by a short list of risk factors that can be recognized, that can be characterized, and we can design interventions that can reduce those risk factors or prevent those risk factors from having the effects that they have in driving chronic diseases. Okay, and that's an important aspect of what we do month in and month out with you as we talk about these chronic diseases. Okay, next. Now, that brings us to a very important observation, and that is this: chronic diseases rarely occur alone. You know, as a professor of medicine, I have often asked, back in the day, I used to ask my residents and my interns if they ever saw a patient that had only type 2 diabetes. That's all they had. They tried hard to find something else, but they couldn't find anything else. If that's all they found, I want them to call me up. I don't care where I was. If I was traveling, if I was asleep, call me because I want to see this person. I want to touch them. Because if you find somebody that only has one condition, a major condition like type 2 diabetes, that's a rarity. If you look at these numbers, in people with type 2 diabetes, 82% of them also have high blood pressure. Another 80% of them are also overweight. That number is now probably higher. And about 80% of them have dyslipidemia, like high cholesterol levels or high triglyceride levels. The prevalence of two comorbidities, that is, other things that are wrong besides the diabetes, occurs in approximately 90% of patients who have diabetes. So when you walk in the door and the diagnosis is made of something like diabetes, and this could be true of other chronic diseases as well, look for something else. Next. Because one of the things that we now know, and of course this involves a whole lot more data and information than we have time in any one of these sessions to share with you, but let me assure you of this. We have learned, for example, that by the time somebody has type 2 diabetes diagnosed, 40% of those people have some underlying problem with their kidney already. What we know is this: if I ask you, what is the leading cause of death in people with kidney disease? Now, many of you say, well, kidney failure. Some of you might be inclined to say that, but no, that's not true. The leading cause of death in people with kidney disease, including kidney failure, is heart disease. They die of heart attacks and heart failure. Because when you see a problem in one of the major organ systems, it's usually an indication that there are major problems in a related organ system. If the kidneys are bad, look for the heart to be dysfunctional. If the heart is dysfunctional, look for the kidneys to be affected. And the same thing is true of other major organ systems like the brain, okay, the circulatory system. And if you look at why that is the case, you see under type 2 diabetes, hyperglycemia right there, you see glucose, AGEs, that's advanced glycation end products, lipids, blood pressure, reactive oxygen species, inflammation, all of these things, fibroses, they share risk factors, the same risk factors that drive defects in one will be operating on other systems in the same way. There are common risk factors across these major diseases. Next. Now, if you look structurally at what's happening underneath, what you find is this: that these common underlying defects, especially inflammation, which you'll hear about a lot, oxidation, bad fats, the end results have many similarities. Inflamed, blocked blood vessels. This is a major problem, okay? And there are other things that people do that make these blockages or this tendency for blockages worse. High blood pressure, smoking, bad diets, stress. And early intervention is extremely important, and we require a team approach to help with these, and we have to have a persistent long-term strategy of treatment because otherwise all of these things become additive. They gang up on us and have long-term poor outcomes. Next. Now, I won't spend a lot of time on this because I think the point to be made is simple. If you look at the left column, under chronic diseases and related conditions, you see the whole laundry list of different chronic diseases that we've talked about: heart attacks, atherosclerosis, diabetes, kidney disease, cancers, so forth. But look at the known risk factors. If you look at each of these conditions, you'll find that there are common risk factors across all of them. And I've highlighted one because it seems it's kind of a surprise. And you heard a very excellent set of presentations on this from our hygienist, dental expert, Melissa Gross, this past year. And you'll hear more about this in coming webinars. Periodontitis, okay? tooth and gum disease, okay, very important as almost a universal risk factor for virtually all of these chronic diseases. Not all of them are reversible. You can't change certain things. You can't change your age. Now you can go to Dr. Reynolds and get some of that fancy surgery and you can look wonderful, beautiful, but your age isn't changed. You know, you're still old, but you're beautiful. Okay. You can't change your genetics. Okay. Your race or ethnicity. Some people try, but you know what? You can't change it. You can change what you look like, but there are certain things that you can change. For example, I have a family history of diabetes. The reason that I'm an endocrinologist is largely because of that. I have a diagnosis of prediabetes, which I've carried for 13 years. Prediabetes is one of those risk factors for progression to diabetes, but you can change it. You can prevent the progression from prediabetes to diabetes by following appropriate lifestyles and all kinds of other things, which I've fortunately, by the grace of the Lord, I've done for 13 years, and others have as well. So what we try to do is to find out those risk factors that can be modified and change them because now you can change outcomes. Next. And then periodontitis, basically it's the illustration of why that is so widespread as a risk factor. It's because bacteria, which can come in through the mouth, they can travel into the teeth and gums, through the soft tissue. They can travel through the bloodstream. They can travel through the gut. They can get to all parts of your body and cause what? Inflammation. And inflammation is a major theme in many chronic diseases, okay? And it is a common underlying risk factor. And that's why you see it so commonly displayed across so many different chronic diseases. Next. So finally, there are things that you should know about chronic disease. You should know, am I at risk? Do I have a family history? You should ask if you don't know. How do you make a diagnosis? Ask somebody. You're saying that I have this. How is that diagnosis made? And is it something that goes through stages? Is there an early stage? Is there a later stage? Because if you can go from an early stage to a later stage, you want to know what is it that can drive that progression? Because I want to know what can I interrupt? And how do I know that I'm progressing? Going either forward or going backwards? Is there a cure? If you're not asking that question, then you're not being curious enough about your own condition. What are the treatments? And are there things associated with those treatments? And then you should be comfortable in asking your primary care provider, how sure are we about this? How long have I had this condition? Is it possible that it's something else? Are there other treatment options other than what I'm on? Am I showing any signs of improvement or worsening? Are there things that I should be avoiding? Next. And then there's this pyramid of treatment. It doesn't matter what the chronic disease is. The treatment pyramid is going to look pretty much the same in overall design. At the base, there are going to be common things. Every chronic disease needs to have the benefit of lifestyle changes. Good nutrition, stop some things like smoking, other bad habits. Physical activity before you go to the various medications that might be useful for your condition. And then the next level, you might need specialized medications like you'll hear talked about from Dr. Fenton. And then even more specialized treatments depending on what the organ system is. Next. And then it takes a team. And I think if you look at this team approach that we should have, this is the team kind of approach that we try to provide you for information about your health and about different chronic diseases through CHP. We try to bring these different kinds of perspectives, this different kind of expertise to the table to talk to you about these different conditions and what we know about them and how to make things better. And finally, next, things that you should be asking. Are you really certain? You should be asking your providers. And then if you ask, are you for imprint certain? And there's nothing wrong with getting second opinions, okay?
Amen.
Can you say the name of your problem? If you got a problem and you can't even say the name of it, you know what? That's not a good sign. Write it down. You ought to know how to spell it. Practice saying it. You can look stuff up, but make sure that you're getting good advice. Know what the names are and the dosages of your medications. It's not necessarily easy, but write stuff down. Don't be afraid to pull out a card or a piece of paper. What are the consequences of missing doses of stuff? What are the consequences of stopping stuff? What is true is this: you stop a medication that you've been on and then you go back on it, it is not necessarily the case that you're going to get the same effects now that you had before you stopped it. Okay, it's important that you know that. And then don't get seduced by all this stuff that you hear about organic this and organic that, holistic this and holistic that, and stuff that you hear dazzling you on social media. You want to know, have they done studies? Have they done clinical trials? Go to clinicaltrials.gov. It's a common clinical website that you can learn about different clinical trials. Okay, last slide. The second part of this is going to be talking about when chronic conditions make their way into acute events. And then the third and final part of this is going to be by Dr. Fenton, who's going to talk about these wonderful new medications in this new day of treatments. Dr. Reynolds, it's yours.
Thank you, Dr. Gavin. Very nice. I love how you always put those things together with passion. And those of you who know me here, see me on the Zoom, I'm a very passionate fellow too. So I tend to attract people that are passionate about what we do by knowing what they're talking about. Dr. Gavin had mentioned about how CHP is reaching out to bring other people into our network. So we have joining us, I just signed a contract with him this week, a nephrologist that look like you and us, that look like you and I, right? He's from out of Orlando. He's truly an African-American. He's from Nigeria. He's been a nephrologist for 30 years. So he'll be talking to you in some super details about kidney disease. We kind of hit the surface of it, but he'll be able to talk to you about even going into dialysis and maybe even a kidney transplant, those kind of things. So that's coming your way very soon. All right. My job basically is to just go over some basic things with you here. First of all, recognize the pivot. If you're having a problem, chest pain, whatever it is, recognize that you have something going on. You pivot to the hospital, basically, and we try to work you up. Strokes, heart attacks, congestive heart failure. I cannot stress enough, guys, the number of patients I've seen through the emergency department that have had chest pain, shortness of breath, and they want to wait until the next day. Right? And what I tell you guys, time is what? Muscle. Time is muscle. So they may come in, they may be a little dragging, a little bit, having difficulty walking, a little flare, speech, that kind of thing. And sometimes double vision. Looking out here, sometimes they can sweat. Those patients are probably having a stroke. I'll tell you another one. And what is it? Time is what? Brain. Time is brain. Brother said muscle, but I know you're saying trying to get out. Just could not get out quick enough. All right. So moving right along here. But it's also important to note that as Dr. Gavin was saying, basically, African American, Black folk, typically, if you find me any disease process, you're going to give me a disparity that's higher among Black folk. Right? We're number one for bad reason, but we're number one, but not for good reason, right? And a lot of that is because we don't have access to, we do, healthcare. And if you do have access to it, you may have doctors that are not very good. Studies have been shown, evidence-based studies have been shown that Black folk get better outcomes, amen, for people that look like us. Now, it doesn't mean it happens that way all the time. I tell people I see some bad Black doctors too. They do exist. So whenever you cannot ask your doctor questions about what's going on with your bodies, I would suggest this. Google what you got going on and then go to your doctor. And just see how they collaborate with each other. It's amazing. If you ask Google the right questions, you're going to get some decent answers. All right. So just remember that. You always want to make sure that you get a second opinion. Now, blood pressures. I'm big into this because this is what I see a lot of in the ER, unfortunately. Saw a lady out here that we're going to get started on some medications fairly right after this year talk here. But normal blood pressure, normal. What does normal means? Normal means that out of 100 people, 51 of them have blood pressures that are 120/80 or slightly lower than that. That's all it means. And typically they were white folks. Well, no blacks included in this thing. We're a little different, right? So you need to know what your normal pressure is. Because what's normal for me may be different than normal for you. And that's important for me as an ER doc. When you come to the ER, if your blood pressure is 130 or maybe, let's say 92, but your pressure normally runs 106/78, your pressure's up. You follow me? So know what your number is, your normal pressure is. Then let the doctor deal with it. I guess from there. Elevated blood pressure, yeah, anything that's greater than the first number is going to be your systolic pressure. That's when the heart pumps the blood out. That's your systolic pressure. When the heart releases against the vascular resistance downstream, that's your diastolic pressure. For us as clinicians, for us as ER docs and other docs in general, what's more important to us is your bottom pressure. Right? You can get excited, and your top pressure will go up. What does not happen though is that peripheral vascular resistance downstream is pretty well stabilized. So if your diastolic pressure is elevated, you need to get that down. And sometimes it's going to be with exercise. As a slide here says, lifestyle prevention, exercise. Maybe 30 minutes of walking every other day, better than none, right? Eating properly. Dr. Gavin had mentioned with this pyramid, there's something about eating. Eating properly. We had the nutritionist on. I'm not sure if you saw Dr. Cotwright, but she talked a lot about nutrition and nutrition safety and securities. She'll be on again, by the way, too. She was super. And a lot of our people come back again because we want you to get the best. So you guys are not getting what I would call just regular docs. You're getting some super docs. And you have access to them. Ask us questions. We love questions. Yes, ma'am. Come from the audience. Yes, ma'am.
Experience bleeding, that vessels that burst in my eye, and it caused excessive bleeding and blindness. They said it was. I had two opinions. One doctor said it was many strokes. The other doctor, ophthalmologist, said that it was prolonged use of the insulin and diabetic medication that went on since 1996. It's not painful, but it's very debilitating.
Yeah.
So, but they said it couldn't happen again after all of these procedures, which are extremely painful.
Okay.
So I'm trying to figure out, will it happen again?
It can always happen again, but let me explain something to you. As a ER doc, we see this all the time too. You
Hey,
get
Dr. Reynolds, can you repeat the
the
question?
question was, she has problems with bleeding. It was in your eye, right? And in your eyeball. And on occasion, you go blind. Is that correct? You can't see. Correct? Yeah. That's what the question was. So really, here's your answer though. A couple of different answers for this. If you cough, sneeze, or do something that you stress down your head, let's say you have strain, have a bowel movement, whatever it is, constipation deal, you may pop a blood vessel in the subconjunctival area. That is called a subconjunctival hemorrhage. It looks awful, but one thing it does not do, it's not affect your vision. Okay? So when you start talking about a visual change with bleeding, first thing I think about is a retinal artery occlusion. And something is going on with the retina, vascular wise, right? And that would cause you to be blind for sure. Typically, that requires immediate going to the ER. We immediately call up the ophthalmologist. And you have what we call an ophthalmologic emergency. So that needs to be treated and dealt with. So I'm not sure how you treated it and how things were treated as you went along, but that's something that we see fairly commonly in the ER. So retinal artery occlusions, where there's total loss of vision, not just central vision, but vision in general, because it means that artery has been shut down and sometimes it'll ooze and sometimes it'll bleed. But the typical bleeding that you'll most likely see is where the sclera of the eye looks like a really beefy red. But you can see, yeah. Inside in the eye itself, yeah.
You're clamping the eye open, lasering the outside of the eye, cutting off the blood supply and injecting the eyeball.
So right. So what you had was a retinal artery bleed. and if it's involving the retina. And it's so important to get on that bleeding process pretty quickly, because if not, you'll lose sight in that vision, in that eye. Bottom line on that. But anyway, let's move along. Stage 1, hypertension. Blood pressure, they say anywhere between 130 to 139. It could be 140, but give it mind. I guess I'll give take a few. And also your diastolic pressure between 80 and 89. Diastolic pressure of 80 is normal, essentially, but 89, okay, I can get it. But it calls for what? Lifestyle changes, plus or minus medications. And also your cardiovascular risk, exercising. Sometimes they have to put you on a statin. Dr. Fenton, I'm sure she'll talk about those things too. Statin is really meant to do what? Lower your lipids and your triglycerides. So you're from that for that. Stage 2. These are the patients that definitely, they have lifestyle changes good. Apparently they have not been doing enough. My pressure is 140 over greater than 90. They need to be treated. And typically, we put patients of color, and again, this evidence-based stuff, on 2 medications, thiazide type diuretic, which is either going to be hydrochlorothiazide, HCTZ, or hydrochlorothiazidone. Similar in that it makes you pee a little bit. You get diuresis, or you just repeat. Let's keep it real. You pee more. The other medication is amlodipine. They found that Black folks get a much better response for treatment for blood pressure with a calcium channel blocker known as amlodipine. Now, losartan is pretty good too, but amlodipine, if you Google what is the best medication for me being an African American for hypertension, and see what you get back with. You'll come back to 2 things: thiazide type diuretic, amlodipine. All right. The other one is, unfortunately, I see a lot of this. Systolic pressure greater than 180. Well, if your systolic pressure is greater than 180, and if you've had a stroke, we have to get you down. We have to get that blood pressure down before we give you any what we call TPA. Tissue plasminogen activated. That's a clot buster, right? But we can't give you that if your pressure is high. So we bring your blood pressure down somewhat first. If all other parameters are good, then we'll give you the injection to bust the clots up for strokes. We had a person from our church here, church family, had a situation just like that. They got taken care of very quickly. If you have a diastolic pressure greater than 120, you definitely need to be in the ER. We need to diffuse the time bomb. We give you IV medications for that. You may still go home, by the way, but we have to get that pressure down relatively quickly, right? So that's important to know that part. Next slide. Okay, go backwards. Okay, severe hypertension is not always an emergency. Why would I say that? Because severe hypertension that needs to be treated, it has to involve an in-organ situation. Headaches could be one. You could be a little confusion could be one. Chest pain could be one. Shortness of breath could be one. Difficulty breathing could be one. So if you have any of those things, then that's a real hypertensive emergency. And we jump on you with all kinds of things. IV medication wise, labetalol. Sometimes we give you something called a nitrite type thing to bring your pressure down fairly quickly. So if you have an in-organ issue, that is, if you have an issue with some other organ system that your blood pressure is affecting, that's an emergency. And those have to be treated like yesterday, pronto. I'm almost finished here, guys, actually, believe it or not. Dr. Gavin asked me to be quick about what I say, so I'm trying to be a little quicker. Yeah, Dr. Gavin did that to me. Yeah, he did. I know he hears me, but I can't see him, but I know he hears me. All right, so hypertension is the most prevalent among Black adults. It's the most prevalent. And what does it lead to? Heart attacks, strokes, congestive heart failure, kidney failure. As Dr. Gavin also said, now I can't say that I'm not an endocrinologist by any means, but I do know what Dr. Gavin says is correct because I see them in the ER. Diabetes never run by itself. That's brothers, sisters, aunts, and uncles, nieces, and nephews. We call those strokes, heart attacks, kidney failure, hypertension for sure, and some other problems in there too, such as cancers. We'll have a nice discussion coming up on September the 12th with Dr. Paul Kahn to discuss that they've done before with us last year, and the year before that, prostate issue in males. Prostate cancer, talking about females that have incontinency of urine and other female problems too. But that's one that's usually very well attended. So that's going to be going out to you guys pretty soon. And that's going to be on September the 12th. You'll see a slide for that later. I'm sorry? Yeah, you can call it urinary incontinence. Your cough, make it a little bit. Doesn't mean, hey, man. It's a very common problem that ladies have, and some men have it too. Especially after what? A prostatectomy. Or I call it roto-rooter. Roto-rooter is when you have to connect like a perfectly. They put a scope up there and they begin to drum out your prostate. And you're urinating like you were here. But from time to time, you may fill on stuff a little bit. All right. So hypertension, we already spoke about that in detail, really. I'm looking for people that come in with chest pain or back pain. Chest pain can be anywhere in the chest. Could be on the left side of the chest. That would be classic. But unfortunately, it could be chest pain on the right side. It could be pain in the right arm, going up into the right jaw, to the left arm, up into the left jaw. It could be almost anything. It could be shortness of breath. It could be, you found that you were walking. You used to walk maybe 2 or 3 blocks. Now you're only able to walk a half a block, right? You tend to break out in a sweat. It's not a hot sweat, it's usually a cold sweat, we call it. Okay, we call it diaphoresis, where you just break out in a cold sweat. So all those different things make us concerned. Neurologic deficits, you may have that too. Seizures, blood pressure gets high enough, guess what? The brain is sensing all of that. And the seizure, by the way, guys, is probably secondary to you have hemorrhagic stroke. The brain does not like blood in it. So therefore you may bleed some. And then you may seize. All right. But you want to make sure you do those. Call 911. Act quickly. Remember, again, I'll repeat it again because you're going to hear it again when we get ready to do our raffle thing here at the church. Okay. Yes, ma'am.
If the doctor gives you a blood pressure law, right? Is the point of the law to find out what your new normal is, or if that patient's going?
Great question. The question was, if your doctor gives you something so you can make a log of your blood pressure throughout the course of the day, I would imagine, keep that doc. Excellent doc, because our blood pressures vary throughout the course of the day. When you first get up, maybe okay. By the time you interact with some of your colleagues, you're right? So maybe around 3, 4 o'clock in the afternoon, get your blood pressure checked too. And then at night. But make sure that the doctor checks your blood pressure. I know I do this because I think I checked it 3 times. Laying down, sitting up, and standing up. Okay? If your pressure drops when you stand up a lot, then we're concerned about some other issue. And check both arms. If your blood pressure is not close to the same in both arms, you may have a little problem in your aorta. That is causing you to have constriction there, and therefore you're going to have a decrease in blood pressure in the opposite arm. I'm talking about differences of maybe 35, 40, 50 millimeters of mercury. A big difference, right? So it's important to know that. I'm almost finished, Marissa. You'll be able to take over life. Control before crisis means measurement, adherence, and follow-up. What that slide is simply saying, this, guys, is that you want to make sure that you check your blood pressure in this case. You're doing yours. I love that idea. And everyone should be doing it, by the way, because it's so important to know what your blood pressure is doing throughout the course of the day. So you don't know when you have to kind of like back it off a little bit. For me, I never back it off. Okay, guys, if it's not, God shows me favor, maybe something. Roll it out. All right, so moving right along here. But you want to make sure again that you validate the home technique and the cuff size. If you're a large person, don't try to use one of those little tiny cuffs. You can do how read. Make sure that the cuff, if you put your 2 fingers in between that, cuff is fine. But if you can't put a finger in there, it means it's too tight. You're going to get most likely an inaccurate blood pressure reading. Yeah.
You should be taking it every day. You should be taking it every day.
I would suggest taking it, being a person of color, thinking that cardiovascular disease takes us out, And it seems like one of the number one causes of that happening is your blood pressure. I take mine sometimes 2 times a day. If I'm having a stressful day, I'll take it maybe 3 times a day. So I mean, but yeah, it's kind of important to make sure that you keep a log of it. In the morning, midday, evening time, laying down, sitting up, and standing up. If you get that to your doc, they're going to be more apt to do what? Take better care of you too. Because you know what you're doing, right? You have to take care of yourself. Yeah. Question coming from the audience. Okay, that's a good question. Yeah. The question was, can you still have a heart attack and your blood pressure is fine? Is that pretty close to being accurate? Yeah. Yes, you can. Remember now, we're talking about clogging up of the arteries too. I mean, it's a combination thing here, right? So if your artery is partially closed, because how close it is. People go in just minimal chest discomfort. They have an angiogram done, okay, a cardiac angiogram, and they find that they're 90% closed. But the blood pressure could be okay, especially if they're on the medications, right? But when that plaque breaks off, that's when it becomes from a small infarct to a major infarct. Because when a plaque breaks off in the coronary arteries, a plaque is it's like a calcium plaque, basically, with cholesterol in it. When it breaks off, God made it so well that platelets will come to the area and seal off the actual area, but it continues to seal it off until you go from a minor infarction to a massive infarction. Those are ones that people don't necessarily survive. I like the question, very good question with that. Can you have a heart attack and your blood pressure is normal? Yes, you can. All right, I'm gonna finish here. Treat the injured organ. Well, we've already discussed that. Dr. Gavin, people know that also. This is basically what ER doctors do, by the way. When you come in with chest pain and stuff, we get you right away. We do ECG, do some studies on your blood, we call it troponins, high-level troponins, to find out if you're having a heart attack. Because you're going to have a heart attack without having what we call a classic ST segment elevation heart attack. That's called a STEMI, right? But a non-STEMI means that you have a heart attack, your troponins are up, and you're having chest pain. That means you're going to give you some medication. So you're not going to go to the cath lab initially. You're going to be treated with medications. Reduce plaques. Well, of course, you reduce the plaques by doing what? Eating properly. Eating the right food, staying off of the fatty foods and that kind of thing. The first hour is diagnosis. And again, remember, time is brain. We're talking about strokes here, right? Time is brain. So you want to make sure that you check those things out. I'm going to move a little faster here. Be fast. Balance loss. Do visual changes. Facial droop. And leg weakness. And speech difficulty oftentimes. But here's my surprise coming up here for you guys. Is it a stroke? Get this down. Is it a stroke? Inability to close the eye, drooping of the right side of the face. Notice I did not say we didn't have both sides involved. I'm talking about the right side of the face. We're talking about difficulty smiling. The smile just simply looks weird, as we say. Tongue may feel different, especially along the anterior 2/3 of the tongue, that's top of the tongue. And we're looking at, oftentimes there could be some pain around the ear area and down to the jaw. So it is a stroke. Some more things there too. Physical examination. So what we're looking at here, we look at physical examination. This is what we do as docs. You do on yourself too. Weakness of both upper extremities and lower extremities. One side of the face. All right. Inability to raise the eyebrow. The patient cannot raise eyebrows. The doc should be raising theirs because it means they have a serious thing called a stroke. That's a central lesion, we call it. Incomplete eye closure. Drooling of the mouth. Attempt to close your eye, an eyeball rolls up and out. Decrease in taste, of course. And the question here, what's your diagnosis? So what's your diagnosis? Stroke? It's not a stroke. It could be inside, right? But there's no weakness in the arms or legs. Okay. They don't have any other issues going on that I'm really concerned about. However, because you don't know if it's a stroke or not, you're going to ER anyways. Right? But here's the diagnosis, guys. That's a real person. You notice that if he closes his eye, the pupil's going up and out. That diagnosis is bingo. What happened? There we go. Bell's palsy. You guys seen that before? Oh yeah, so it's pretty common, right? For us, it seems to be more common, right? So when you see someone like that, again, it's only involving one side of the face. That's what we call the seventh cranial nerve, which is the facial nerve. 3 motor branches it gives off. One going up towards the, I guess the forehead. That is called the cephalic branch. One is going towards the eye, ophthalmic branch. One is going towards the jawline. That is the mandibular branch. So the mandibular branch causes him to have his mouth twisted to the left. Therefore, he's going to talk a little funny, probably, kind of like a stroke, right? But what you're not going to see in the stroke is, if you look at his forehead and we ask him to look up, he cannot raise his left forehead skin, only the right. That's the good news. Good news, he has not had a stroke, but you still do your CT scan. How do you treat this? This is emergency too, by the way. The longer you wait to treat this thing, the more permanent it becomes, like looking just like that. We talk about anywhere between 1 to 3 days of high dose steroids, prednisone, 50, 60 milligrams, tapering them down over about 10 days or so. And we sometimes give them acyclovir, right? Acyclovir is something that we use for herpes simplex type 1, because there's an association with herpes simplex type 1 and the inflammation of that nerve, right? But if you wait long, more than 4, 5, 6, 7 weeks or such, now your prognosis of getting back to looking pretty doggone normal is pretty slim. You end up sleeping with a patch on your eye for the rest of your life, lubricating those eyes too, because you just can't shed it. I think I'm done there. Congestive heart failure is a pump failure, basically. When we say heart failure, we're talking about basically the left pump is failing, and it cannot pump blood out. So you end up with shortness of breath. You can't walk very far, swollen legs, swollen ankles, you just name it, and confusion, whole extremities. And again, you want to do your weight. You want to check your weight. If you have a fluctuation of your weight and you have shortness of breath too, but you notice that your weight went up overnight about 5 or 6 pounds. So everyone should have a weight scale, because you're retaining fluids. When you retain the water is heavy. When I talk to my cosmetic patients, I tell them, hey, listen, fat is not heavy. Fat is light. It just gives you bulk. What's heavy in your body is what? Bones, muscles, and fluid. This is one last slide here. So again, recognize, change, act early. Whatever you think is going on, don't you be the doc. Don't Dr. Google it. Get to the ER and be checked out. So Dr. Fenton, it's all yours.
Okay. Hello. Thank you for giving me the opportunity to speak today. I'm Dr. Fenton. I'm excited to talk about this important topic. So I'll be discussing the medication portion and tying everything together and hopefully connecting those dots. So next slide. So for years, patients have been told, we either have diabetes, high cholesterol, high blood pressure, or heart disease as if they're separate problems. The new approach is to recognize that many of these conditions share common underlying mechanisms and that treating those connections can help protect the heart, brain, kidney, and blood vessel. So when we talk about a new day in treating, we are simply shifting from treating isolated numbers or individual diseases to treating the interconnected cardiometabolic system. So the goal is to help us understand that chronic diseases are interconnected rather than separate problems. So the old way, diabetes, you treat the blood sugar. High cholesterol, you're treating cholesterol. Heart attack, you're treating the heart. Stroke, you're treating the brain. The new day is one connected cardiometabolic system, and we're identifying the underlying risk, treating early, and protecting multiple organs. So that's an important shift in how patients understand these medications. This is a simplified illustration of how elevated blood sugar can turn into a heart attack. Next slide. So type 2 diabetes is now recognized as a disease affecting multiple organs. So this picture shows the different organs, like we've got the kidneys, liver, and the pancreas that play their part in causing high blood sugar. And then the different ways medications can attack to help bring down blood sugar. I'll go over a few of these medications in the next couple of slides. Next slide. So to optimize effects of the newer agents in the highest risk groups, we must have trust in the science. So a new day for chronic disease treatment. These mechanism of action, or how the medication works for SGLT2 inhibitors and GLP-1 receptor agonists, is well established and presumed to be uniformly applicable. This picture is illustrating those medications and where it's working in the body. So I'm going to explain what your pharmacist wants you to know about diabetes. Okay, so for the SGLTs, so we want to control a range of factors related to cardiovascular risks. So with medication classes called the sodium glucose cotransporter 2, so SGLT2 inhibitors. So think of your kidneys as a filtration system, and these medications change how your kidneys handle glucose and sodium, resulting in more glucose being passed into the urine. The clinical story is much bigger than that, though. These medications can protect your heart and slow down progression of kidney disease. So when we're thinking of these medications, we're thinking Farxiga, Jardiance, and Kavana. So for appropriate patients with type 2 diabetes, SGLT2 inhibitors with demonstrated cardiovascular benefit can reduce cardiovascular risk. And this class has an important benefit related to health failure heart failure and kidney disease. So the American Diabetes Association recommends SGLT2 inhibitors for patients with type 2 diabetes who have chronic kidney disease, heart failure, or high cardiovascular risk, independently of their baseline hemoglobin A1C levels. So these medications provide organ protective benefits that modify disease progression. So think heart and kidney protection. So again, they play multiple roles beside glycemic control. So they decrease blood pressure, they decrease weight, they decrease triglycerides. So we just want to make sure that when we think of SGLT inhibitors, they're more than a diabetes pill. Next slide. Okay, so now we're going on to GLP-1 based therapies. So this is not just about blood sugar. So these therapies can improve blood glucose, reduce appetite, promote weight loss in appropriate patients, improve several cardiometabolic risk factors, and for specific agents, reduce that cardiovascular events that Dr. Reynolds was speaking of. So some GLP medications do more than lower blood sugar in people with type 2 diabetes. So certain GLP medications have shown in clinical trials to lower the risk of major cardiovascular events. What we're including is heart attack and stroke. And so this is just a diagram that's showing the different body parts and how it's being reduced. Next slide. Okay, so these are the different types of GLPs. The ADA specifically identifies liraglutide,
Last night, about
semaglutide, and dulaglutide among the currently relevant GLP receptor agonists with demonstrated cardiovascular benefit. So think Victoza, Trulicity, Ozempic, and Rybelsus. So both the injectable and oral formulations have evidence to reduce the heart attack and stroke. I'd like to note the adjunct to diet and exercise statement in this graph or in this chart. We cannot forget everything that Dr. Cartwright taught us last seminar about nutrition. So we have to make sure our nutrition is working with us. Like we discussed before, we can't control our family history, but we can control what we eat.
Everybody get the,
Next slide.
everybody get that?
Okay, so then statins more than a cholesterol pill. So these are tried and true, nothing new about them. Statins came out in 1987. So, but when we talk about medications working together on different disease states, this is a prime example. So statins are prescription drugs that lower bad LDL cholesterol. They work by blocking a liver enzyme needed to make cholesterol, which helps clear cholesterol from the blood and stabilize plaques in the arteries. So statins are common medications in patients with heart disease, stroke, high cholesterol, because they lower the risk of developing heart disease and having a stroke or having a heart attack. So the American Diabetes Association and the American Heart Association both advise that most patients with diabetes take a statin. You will hear it sometimes coined as SUPD, so that's statin use in patients with diabetes. And they recommend high intensity statin therapy to reduce or to achieve a maximum benefit for heart protection. So high intensity cholesterol medications, you're thinking atorvastatin, specifically the doses of 40 to 80, or rosuvastatin, 20 milligrams to 40 milligrams. So again, we're adding a cholesterol lowering medication for patients with diabetes due to patients having a greater risk for heart disease. Statins include Lipitor, the atorvastatin, Crestor, rosuvastatin, Zocor, simvastatin. And there are other intensities, but those are just a few. A great question I get asked a lot is, my cholesterol isn't that high, so why do I need a statin? So diabetes itself increases cardiovascular risk, right? So that's why statin therapy isn't based solely on whether a patient's cholesterol looks high. The statin isn't treating your blood sugar. It's treating one of the major pathways that can lead to heart attack and stroke. And before you guys come for me, I know statins can cause muscle pain, and it can be severe to the point where you have to stop or you have a statin intolerance. So the American Diabetes Association points out, and it recommends that finding a tolerable statin dose or alternative rather than abandoning lipid lowering therapy altogether when adverse reactions occur. So that includes taking like high intensity statins every other day or even twice a week, or having a lower intensity statin I was talking about. You could discontinue statins, but they do recommend taking like Repatha, Praluent, Zetia, other medications that have that lipid lowering therapy. Next slide. Okay, so the American Diabetes Association, this is the 2026 Standards of Care, specifically recommends considering medications with demonstrated cardiovascular and kidney benefits in appropriate patients with type 2 diabetes, even when additional glucose lowering isn't the primary issue. So I just wanted to point out that this chart is for prevention of the atherosclerotic cardiovascular disease, so ASCVD, in patients with type 2 diabetes, which is this simple term of having blocked or narrow arteries restricting normal blood flow, which can lead to heart attack and stroke. And I'm not going to go too much into the chart, but I'd like you, if you follow the questions, it's interesting to know that whether you have established or a risk factor, whether the answer is yes or no, you're still going home with a statin. Looking at the chart too, there's that nutrition and lifestyle management in blue before we even start asking the hard questions. Next slide. Okay, so managing diabetes often means more than watching A1C. Your healthcare team also needs to pay attention to your blood pressure, cholesterol, kidney function, weight, and cardiovascular risk. So this is just the big picture. If we control the risk factors, we protect the blood vessels and we protect the heart, brain, and kidney. So lifestyle modification, what we learned last webinar with nutrition, and diabetes education, what we're learning right now, are the right steps towards reducing diabetes complications. Next slide. Okay, so the pharmacist role. So the pharmacist becomes the person who connects the dots for the patient. So the goal is for me to help you understand why you're taking your medication and what the medication is protecting, what to watch for, and what questions you are asking. So the next time you go to pick up your medications, don't just ask, what is this pill for? Let's ask, what is this medication helping protect, and how does it fit into the bigger picture of my health? The it Why we want that to happen is it opens the door to discuss modern treatment strategies, including medications that may address more than one aspect of cardiometabolic risk, alongside nutrition, physical activity, weight management, smoking cessation, blood pressure control, and cholesterol management. So take a picture of this. There's nothing wrong with having it on your phone when you go up to make sure you're asking the right questions and the whys behind why you're doing it. So what is each medication supposed to protect? Do I have cardiovascular or kidney disease that changes which diabetes medication I should take? What side effects should make me call you? Are there any of my medications interacting? Do I need to change anything before surgery, or if I'm sick and can't eat? Because some medications you're taking, it could lower your blood sugar, but you're not eating. We've got a hypoglycemic issue now, which is far more serious than hyperglycemic, high blood sugar. And then lastly, when should I take my medication? So I can already tell you quickly, your statins are at bedtime. Why? Because cholesterol production is highest at night. And the American Heart Association recommends one blood pressure medication should be at night to help from that heart attack and stroke. So we are no longer about diabetes, heart disease, and stroke. We are looking at it as connected pieces of your overall health. Your blood sugar matters, your blood pressure matters, your cholesterol matters, and your kidney function matters. And the medications you're taking may be doing more than simply treating a number on a lab report. So once we understand the connection between chronic disease, we can move forward from simply treating the disease to preventing complications and protecting the whole body as a whole. So that's all I have. Does anyone have any questions before I turn it back over?
If there are questions, please feel free to put them in the chat box, or you can use the hand raise sign off of your computer. So if there are questions that you have now that we can address on any aspect of what you've heard here today, we have a few minutes that we can devote to those. And please don't consider any question too naive or too provocative for us.
We have one question, Dr. Gavin, from raised hand from Dr. Joseph Webb III.
Okay.
Yes, good afternoon at this point. Great stuff. Yeah, I have a question on the blood pressure, Dr. Reynolds, and I may have missed it as far as what could be deemed as normal, because I've been told that too with the variances. So I can my lower number is, is always in the 60s and 70s in general. And if I've just eaten, of course, and I take it, then I may hit 80. But my lower number is always in, for what you all are seeing, in a good space. It's that upper number that can go as high as 160, and then it'll linger between 130 and 140. And wanted to get your take on that. I am taking a blood pressure medicine. I'm taking a hydrochloric thiazide with potassium, and then there's another one too I can't think of. But yeah, I'm like just there in that those borderlines, and I just wanted to know. I just wanted to get your take on that. Thank you.
Okay, that question I think was directed to Dr. Reynolds. You're on mute. While Dr. Reynolds is getting his mic back in possession, let me first point out that we have to really be mindful of the fact that there are standards that are set by organizations like the American Heart Association, and other organizations like that define what you expect as a quote normal blood pressure. And then there is the physiological meaning of normal and low blood pressure. Let's start with low. Low blood pressure is any blood pressure that is insufficient to maintain your body functions. So that's why we ask people not to get too concerned about a number on the low side, as long as you're able to pee. Because remember, your kidneys are still functioning, your heart is still beating, your brain is still functioning, your blood pressure is high enough to maintain those functions, okay? High blood pressure, on the other hand, is a different issue, because there you may get into problems and not know it if you're not measuring, okay? So that's when these standards become much more important. But Dr. Reynolds, you want to address the question that was proposed by Dr. Webb?
I think he's not able to answer at the moment, Dr. Gavin. Looks like he's tied up at the event that he's
Okay.
currently at.
Well, I would say, Dr. Webb, that notwithstanding the comment that I just made about low blood pressure, where unless you're having physiological issues to suggest that your blood pressure is too low, on the high side, now it's important to generate a number by measuring. Okay, because there, what we do know is this, that if you are out of a certain range on the systolic blood, that top number, if that blood pressure is outside of a certain range, say higher than 140 over a relatively long period of time, on average, you start getting into problems with the development of consequences. That is, your blood vessels start to become constricted. You start to have the tendency towards plaque formation if your lipids are not well controlled. There, you need to know whether or not that number is in that range, and if it is not, it may mean that you now need to do some other things like change your blood pressure medications, make some modifications in your diet or your physical activity. Does that help at all with that?
Yes, sir, it did. Thank you. I appreciate
Okay.
it. Thanks.
Any other questions, Fred?
Yes, sir. I think I'll pose this one to Dr. Fenton. I have a woman in here who says, what is the best medication to take for high blood pressure as a African American woman in my 30s?
Well, that's a great question, and it's going to depend on what kind of high blood pressure are we talking. So I have to know the numbers of what blood pressure medication you're on, or how high how high is high. And so without that information, it's like Dr. Gavin said, there's a standard of care. So there's guidelines to chart to determine, if we're going to start loop diuretics like the hydrochlorothiazide to bring down your blood pressure, or if we're going to do an ARB like losartan. So it kind of just depends, but those are the classes that you would be taking.
And
Next
could
question.
I also
Yes, sir.
add to that, to Dr. Fenton's comment? One of the things that we are really trying to make people sensitive to is the importance of numbers. Okay, one of the rabbit holes that we've gone down into over the years is we've started talking about things that should be spoken in terms of numbers. We've started talking about them qualitatively, that it's okay. It's normal. Well, no. You need to know what standard you're talking to. And those standards are measured standards. So when there's a blood pressure, that blood pressure is expressed as a number, the systolic over the diastolic. And that's the number that you should be using as a frame of reference for your discussion. Because if you start talking about, well, it's okay, it looks pretty good, that's not helpful to anybody, because there's a lot of relativity there and a wide range of possibilities, and you don't want your health to be thrown into a bucket with that wide range of possibilities that's all over the map. Talk specific numbers, and somebody should be measuring something, writing something down so that you can talk in terms of what the numbers are and what the numbers are that you are trying to work towards, because that's what the end game ought to be.
Next question. Miss Arden asks, what are your thoughts on the blood pressure medication called telmisartan? I believe I pronounced that correctly.
Yes.
either for you, Dr. Fenton
I
or
think
Dr.
Dr. Fenton has already opened up the notion of the angiotensin receptor blockers, ARB. So you might want to just talk about that.
Yeah, so and like what Dr. Rundle had stated before, those are the better options than, because you could do either an ACE angiotensin inhibitor, or you could do the ARB. But for African Americans, we're more going to be leaning on the ARBs. So telmisartan is another tried and true medication.
Very good medication. Yeah.
Continuing, some of these questions may have been addressed, but we'll just double check here. I got Miss Tammy Davidson. What is the best remedy for inflammation?
Well, again, we have to be really careful because inflammation is one of those things it's a broad concept. Okay. For example, obesity is an inflammatory state. Okay. Kidney disease is characterized by inflammatory changes in the kidney. Heart attacks are associated with inflammation in the coronary vessels. So the inflammation is a widespread concept. There are general anti-inflammatories. We know of them, for example, aspirin, non-steroidal anti-inflammatory drugs like Aleve, naproxen, ibuprofen. Those are anti-inflammatory drugs. So it's a wide variety of options, but that's because inflammation is a widespread process that can affect a lot of different parts of your body. But those general anti-inflammatories can be a start, but then depending on the extent of the inflammation. I just had knee surgery a little less than 2 weeks ago. And let me tell you, I'm married to this one of these anti-inflammatories. It's become my new best friend to help reduce, the swelling and the pain. But it could be that a different kind of inflammation, I would need a different kind of inflammatory process. Marissa, you want to add to that?
Yeah, yes, I agree. Because there's a wide variety of medications that can help with inflammation, and also the types of food we eat can help with inflammation. So we have to kind of pinpoint with your medical history what inflammation we're trying to treat.
Priscilla, I'm going to come to you next. I have one, the Miss Coleman, who asked the question about the high blood pressure in African American women in their 30s, responded and said, sometimes it varies from 145/95 or 150/93 is the range it's normally in, and amlodipine is the prescribed med.
Right. So that's a calcium channel blocker. Another great tried and true medication. And they will start you on it. And then we have to make sure, well, one thing I'd like to talk about too is being compliant. So once they start you on the medication, making sure you're taking it every single day and seeing if, if your blood pressure is decreasing. If it's not, then we're going, to add another regimen. But we definitely need to make sure that we're taking it every day, because if we're going to the doctor saying we are and we're not, that can kind of come up with problems too. So amlodipine is a good choice. This is a science when we think about it. So what would work for one may not work for another. So if we try the medication, and then we have to get our lab work to make sure, we're checking our liver function, our kidney function, then you go from there.
Miss Priscilla Corner, your hand is raised. Are you there?
Dr. Fenton mentioned all about the new process of treating all of the different problems together, the heart, the brain, the diabetes and all of that. She mentioned several medicines. I'm a little bit older now, and they're saying I'm borderline with a lot of things. Okay, so that preventive, all those medicines she mentioned, is she saying that to take all of those and they kind of now have figured it out that they work together? Or have they reduced it into 1 or 2 pills rather than, because I don't take hardly any medicine, so I'm not trying to, I've been trying not to get to that point. So is there, when she mentioned all those medicines that worked all the different parts, is she suggesting that on a preventative measure to take those pills, all those different ones? Or have they come up with something that we could take all at 1 or 2 pills?
No, so it's more to show you that these medications are tackling more disease states than what it used to. So like SGLT2 inhibitors, that was
Mhm.
always, you always knew that medication for diabetes. And so now we're seeing that it has cardiovascular effects. So if you have, like normally you could look at a patient's profile and see Jardiance, and I could be like, oh, okay, I know that patient has diabetes and we're treating it as such. It's not like that anymore. There, you could be on Jardiance and not have diabetes, and we're just protecting your heart or your kidney. So it's heart and kidney protection. So it's just explaining how these medications are attacking more disease states and how it's all interconnected. Somebody in the chat had mentioned, you know, I have high cholesterol, and that's the only problem I have. But
Mhm.
again, we have to remember that we don't have more than one body. We're working, everything is working within the one body. So if you're having high cholesterol, you're having other issues.
Right.
And we have to decrease that so that we don't further that progression in those other disease states. So I think it's those medications that I had listed, it's like statins is a cholesterol medication, but when we're taking it, if you have diabetes, you are going to be placed on a statin. So I think it's just understanding that these medications are working on more than what you think of one disease state.
And if I could just add to that,
Right.
there is what we call an approved indication. The FDA, when a drug is approved for use in a patient to treat a condition, that's what goes in the what's called the patient package insert, the instruction that goes to patients that you can read and show what the FDA approved this drug for use in. These SGLT2 inhibitors that Dr. Fenton talked about, they were initially approved for type 2 diabetes. But other studies showed that they not only affected the glucose levels in type 2 diabetes, but they also improved kidney function in people with type 2 diabetes. Same drug, same doses. They improved blood pressure. They improved heart failure. And so when it was shown to have a sufficiently strong benefit for those other things, the FDA allowed the inclusion of those drugs as approved for those other conditions as well. And that's where we get these new, what Dr. Fenton referred to as these new day findings of one pill, one drug that now has been approved for beneficial effects on a variety of things. And that's being shown now for more and more drugs. Sometimes some of these drugs that were initially approved for diabetes, now you don't have to have diabetes to take them because their benefit for other things is so strong that you can actually take those drugs for those purposes. Well, Fred, I think we've gotten to the end of our time. Please, it's the closing time for where we are. We appreciate your questions. And if you have additional questions, please remember that you can send those in to us and we'll try to get back to you on these important questions because they've been really insightful questions and we appreciate your sticking with us and showing up here today. So I will happily lead us. So if we assume an attitude of prayer, Heavenly Father, we are thankful for this opportunity that we've had to convene and to share insights and to share information for these, your people. Bless each and every one that has attended. We ask that you continue to watch over them in their comings and goings and bless us in our future efforts. And as we depart this place, please go with us with your hedge of protection always. In the precious holy name of Jesus, we pray. Amen. Thank you all so much.